and professional collaboration. As one of the largest doctors platform in India, we proudly serve over 8.4 lakh healthcare professionals. Our platform offers a wealth of resources, including short videos by global KOLs, live webinars, case discussions, daily medical news, and evidence based journal. Today, we are privileged to have Dr. Ritu Sandwani, a distinguished gynecologist, as our speaker. Dr. Ritu's profound expertise and groundbreaking insights will undoubtedly enrich our understanding of the topic at hand. Without further ado, I'm pleased to hand over the session to Dr. Ritu, who will be discussing on the topic of navigating ovulation induction for effective IUI treatment. Over to you, Dr. Ritu.
Yeah. Thank you, Sanika. A warm welcome to all dear friends, those who have joined. Yeah. Let's full screen. Yeah. And thank you, Medisage, for doing such nice academic initiatives. I believe that knowledge sharing is the power. The more the knowledge you share, more the powerful you are. At the time when I passed out 24 years back, the net was not so strong. So it is from the time of the lockdown, the awareness is increased very much. So I always prefer to share as much as knowledge, what I can gain, what I have gained, and by sharing also we get also the lot of knowledge. So friends, today the topic which I am going to discuss with you all are very important, that how to get a very good follicle while doing the IUI. So as Sanika has given my introduction, I am practicing in Pune. And friends, I am on every social media. You can connect with me on any of the social media and we can share the knowledge. Facebook, LinkedIn, Insta, YouTube, any the platform we can connect. So, namaste to everyone and Assalamu alaikum, because this is the holy month of Muharram is going on. My all presentations always start with Mata Durga Stuti. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. Now coming to that, how we get a very good follicle while we are planning for the IUI. As once the patient is approaching us for the IUI, the patient's hope are like that of course in the first cycle only, madam, there should be a positive result. Though we always explain the patient, the success rate depends on the 3 cumulative cycles. So now what the drugs we can use and how can we give the good results? Today we are going to discuss on that. So friends, as we all know, there is no such tailor-made protocol for every patient. We have to see the parameters and accordingly we have to give the drugs. So the stimulation for IUI goals, the improvement of the follicular growth, increasing the number of follicles, treatment of anovulation, especially the PCOS patients are coming who are having a problem of anovulation, better timing, improvement of luteal phase. Why this combined ovarian hyperstimulation is filled with IUI for navigating the good results in the cases of the IUI. So as we all know, to provide the more number of the follicles with good quality, the timing of HCG injection predicts the ovulation better so as to schedule the IUI near the ovulation time. COH offers more over for fertilization and implantation, hence increases the success. COH corrects the subtle endocrinopathies which block ovulation and implantation. So friends, now coming to the factors one by one, the male factors and the female factors. Among the male factors, as we know, the retrograde ejaculation, impotence or ejaculatory dysfunction, hypospadias, hypospermia, non-liquefying or highly viscous semen, subnormal semen parameters, seminal antisperm antibody, and unexplained infertility. So a lot of patients we are getting who are coming with these issues. Among the female factors, the vaginismus, cervical hostility, ovulatory dysfunction, mild endometriosis, allergy to seminal plasma, unexplained infertility. Lot of patients we see that all the parameters are normal in both the partners, but still they are not getting the good results. Just a second. Hmm. Hmm. Among these female factors, the vaginismus, cervical hostility, ovulatory dysfunction, mild endometriosis, allergy to seminal plasma, and unexplained. Usually, some patients we are seeing in which both the factors are coming normal, still the pregnancy is not happening. So we usually tell to go for this any of the ART procedure. Of this, the basic one is the IUI, with which we get in some patients are really the good results. Among the endometriosis, as I mentioned, the mild endometriosis, that is especially for the grade 1 and grade 2. Grade 3 and grade 4 endometriosis, if the patient is having, please don't waste time on the IUI. The results are not going to come. For grade 3 and grade 4, IVF will be the ideal. So, the donor semen IUI in the cases of the azoospermia with testicular failure, several abnormal semen parameters, hereditary disease in men, severe untreatable RH isoimmunization in wife, repeated failures with IVF or ICSI, single women, and the lesbian couples. So now, which protocol we have to use? The protocol should be simple, cost-effective, minimal side effects, with the best success rates. Patients requiring the ovarian stimulation or induction can be categorized in two groups. Ovulatory patients, the ovarian stimulation. In these patients, there is an established ovulatory pattern. Multiple studies have shown improved pregnancy rates with ovarian stimulation in these patients as compared to the non-stimulated natural cycles. Why? Because we have an aim for the multiple follicle development. Among this anovulatory patients, the ovarian induction, 20 to 30% of the cases of female infertility. Anovulatory patients are further divided by WHO in three categories. As we all know, friends, the group 1, hypogonadotropic hypogonadism, group 2 in the PCOS, in the group 3, the ovarian failure. In these cases, our aim is to have a monofollicular. As we all know, for the success of the IUI, at least we need the minimum two to three good follicles. If even if you're having the two follicles, the results also come very good. So as I mentioned earlier also, the one size doesn't fits all. So there should not be, there is nothing like that as some tailor-made protocol. So, so for every patient, we have to decide that how the response is coming, how the response is coming. Huh. Sorry, huh? So the first step for the success is to take the exact measurements. So we have to see according to the patient that what is the BMI, what is the age, what is the AMH value, that how we have to give the drugs and which drugs are going to give the good results. So friends, what the statistics have shown, in the patients with natural cycle and IUI, the success rate is reported 3.3. With CC, it is reported 9.5. With letrozole, it is reported 11.5. These days, we are using the letrozole. And if we are using along with the gonadotropins, then the result is reported 13.3. With only gonadotropins is up to 17.26%. So as we all know, with the gonadotropins, the results are good. So only the thing is the cost will be goes little more. So according to the patient, and we have to discuss with the patient in detail. So now the number of follicles in the pregnancies per cycle, as if you're having a one follicle, 5.7, two follicle, 13.6, three is 16.3. If 4 or more, 13.9%. But with that, of course, we have to be prepared that the chances of going for the OHSs are very high. So it's much better that the higher pregnancy rate has been reported with 2 to 3 pre-ovulatory follicles. So, what are the pre-induction checklist is required? The day 2 FSH, AFC, ovarian volume, AMH, and HST to know whether the tubes are patent or not. Not we need diagnostic lab pro and histo in every patient, but then yes, in some patients where the results are not coming, of course we are advising. But of course, the day 2 FSH also we are not telling every patient to do, otherwise the cost increase so much. Usually the AFC and AMH are the two basic criteria, and of course the via HSD we have to know that the tubes are open or not. So again it is muted. Hmm. So now what are the regimens we can use for this? So friends, as we all know, the CC, clomiphene citrate, letrozole, gonadotropins, or the CC with gonadotropins or letrozole with gonadotropins. uh, Gonadotropins with GnRH analogs and gonadotropins with GnRH antagonist has been reported. So now why not to go with the spontaneous? What the studies have shown, the cumulative pregnancy rate per couple was 33% for IUI and COH and 18% for IUI alone. COH has independent positive effect on pregnancy rate when combined with IUI. In young patients without a prior pelvic surgery with good post-wash semen quality, COH doubles the IUI pregnancy rate. Hmm. Hmm. With the CC, the studies have shown that it is this drug, CC and letrozole both are most widely used, simple to use with the minimal side effects and cost effective. Yes, of course, we are using either the CC or letrozole depending on how you are more convenient and how you are more comfortable. So with the CC, the mechanism of action, the hypothalamus pituitary, and as we all know, the CC binds to estrogen receptors and depletes the receptor concentration. FSH stimulation concentration, it causes the more smaller follicles are rescued, multiple follicle development. So this is actually the basic mechanism of the action. Dosage, as we all know, 50 to 100 mg per day for 5 days, up to 200 mg per day has been reported. So, but in the practice, yes, of course, I have not used any time more than 150 mg. There is no difference in pregnancy rate, whether clomiphene is commenced on day 2, 3, 4, or 5 of the cycle. Although there is perhaps a tendency to multiple follicular development, the closer the agent is commenced to menses. Outcome after the CC has been reported pregnancy is 30%. Failure is no pregnancy despite ovulation 40%. Resistance, no ovulation 25%. Anti-estrogenic effect 5% has been reported. Then this CC, the mode of action, the competitive binding of CC to estrogen receptors in the hypothalamus stimulates the release of GnRH, gonadotropin release from the anterior pituitary, leading to follicular growth and maturation, increased estradiol production, and the stimulation of ovulation. The dosage, as we all know, the 50 mg once a day for 5 days, starting from the day 5 of the menstrual cycle, depending how you are comfortable, day 3 or day 5. And the ovulation usually occurs 5 to 12 days after the fifth dose is taken. Maximum dose is rated up to 200 mg for 10 days for the obese women to start with the dose of 100 mg. The success rate has been reported. The ovulation rate is 70%, pregnancy rate 40%, pregnancy rate 40% is up to multiple pregnancy. Then, इकडे द्या. CC resistance, failure to achieve ovulation. Failure to achieve ovulation 20 to 25%. Hmm. Hmm. And CC failure up to 60% has been reported. Hmm. Hmm. So, the disadvantages of the CC have been reported: the longer half-life and receptor depletion, prolonged peripheral anti-estrogenic side effects, cervical mucus, dryness of vagina, itching and discharge, endometrium thinning in 15 to 50%, higher incidence of miscarriage, decreased blood flow during the early luteal phase. Second, the common most drug these days, what we are using is the letrozole, and it shows the excellent results in the cases of the CC resistant and CC failure. Yes, of course, the main disadvantage with the CC is the thin endometrium that is not with the letrozole. So associated with thicker endometrium and increased stromal blood flow, and thereby providing a better uterine environment more favorable for implantation. Compared to CC, letrozole has been shown to have a higher pregnancy rates. So here the mechanism of action, friends, here we can see it inhibits the aromatase in ovary and peripheral tissues, reducing the estrogen level. Negative feedback in turn actively stimulates the HPO axis. The GnRH releases the more FSH and more follicle, and filtering estrogen level from the follicle suppresses the FSH, leaving a single dominant follicle, which is very good in the cases for the where we are advising for the natural intercourse, or and the chances of the OHSS are nil. So dosage, as we all know, the dosage has advised to start 2.5 mg per day from day 3 to day 7, or up to 5 mg. I will show you the further slides of the extended protocol also. Higher rates of the monofollicular, no direct anti-estrogenic adverse effect on the endometrium, shorter half-life, 48 hours, and lower serum level of E2. So extended letrozole therapy, the 2.5 mg daily from the day 1 of the menses for 10 days was used in CC-resistant PCS women. Higher number of patients ovulated, number of dominant follicles are more, pregnancy rates are significantly higher, and no extra cost. So today the aim of discussion that why to get a good follicle, how what the protocols we can use. So we can use either the CC or letrozole. Of course, the letrozole, the safety is more, the chances of side effects are less. So we can use either the different protocols. The dose is 1, 2, 3, or 4 tablets on the menstrual cycle day 2, 3, 4, and 5 respectively. Multifollicular development, higher pregnancy rate. Starting dose is 2.5 mg per day. Cycle days 3 to 7 following a spontaneous menses or progestin-induced bleed. If the cycle is ovulated but the pregnancy has not occurred, the same dose should be used in next cycle. If ovulation does not occur, the dose should be increased up to 5 mg per day from the days 3 to 7 with a maximal dose of 7.5 mg per day. Sequential dose escalation 2.55 and 7.5 mg if the ovulation does not occur on the lower doses is widely used. So ideally, we are using the 2.5 mg. Then if no results are coming, yes, 5, because to me, the patients who all are approaching me are coming after they have taken long treatment outside. So I usually start from 5 mg along with the gonadotropins. So this is the sequential escalation protocol or the step-up protocol for the successful superovulation. So if ovulation does not occur, the dose should be increased to 5 mg per day cycle from 3 to 7 with a maximal dose of 7.5 mg per day. Sequential dose escalation 2.55 and 7.5 mg if the ovulation is not occurring with the lower doses. So a lot of studies have come in the favor as reported in the Fertility Sterility Journal also. So the studies have shown the escalation protocol increases the ovulation rates in the patients with PCOS by effectively identifying the letrozole necessarily to achieve the follicular recruitment during the initial ovulation induction cycle. Immediately increasing the dose of letrozole in a single cycle does not exhibit the detrimental effects on the number of follicles recruited, endometrial development, or pregnancy rates. So here, friends, we can see for the extended protocols recommended by the ISHRE. So 2.5, then day 4, 5, then day 5, 7.5, and day 6, 10 mg. Then letrozole, with this, the studies have shown some more success and higher chances of the pregnancy rates. So with this super ovulation, the conclusion by this protocol that this protocol is proved useful for the in cases of the ovarian hyperstimulation for assisted reproduction. So overall, the pregnancy rates associated with the use of an aromatase inhibitor for an ovarian stimulation. So a lot of studies has been presented in the favor of this. So we know comparing the CC and letrozole. For CC, the large follicle early in the cycle, while in this, the larger follicle will letrozole. With CC, the cystic follicles. So poor blood flow to the follicles, thin endometrium, poor blood flow to the endometrium, and higher chances of LUF. While here we can see here we can see the larger follicle size early in the cycle. We don't have to give the trigger unless the follicle is 20 mm to improve the oocyte maturity, perifollicular blood flow, endometrial thickness, and vascularity is normal. Gonadotropins indicated in CC failure, letrozole failure, WHO group 1, hypogonadotropic hypogonadism. Gonadotropins might be the most effective drugs when IUI is combined with ovarian hyperstimulation. For this, the dosage has been recommended is the FSH or HMG administered daily from early in the menstrual cycle. Monitoring with USG is mandatory. Trigger the ovulation with HCG when follicle maturity attained. Significantly improve the pregnancy rates from IUI in contrast to the natural cycle IUI. Risk of the multiple pregnancy is high, of course. So the advantages in this, the higher efficacy, ovulation rate more than 95% per cycle, conception rate 20 to 30% per ovulatory cycle. Limitations are serious complications can occur like multiple pregnancies, twins 25% or maybe the triplet also, OHSS. Yes, long-term complications which has been reported the ovarian cancer, but that is on the very higher extent, usually no. Requires the intensive monitoring in the specialist center and it is expensive. But friends, what I suggest, if you are having a sonography machine with you, the better results will come definitely with the gonadotropins. To save the cost, you can give with the letrozole along with the gonadotropins. That will also give the good results. Depending on the day 2 LH, FSH, E2 levels, if the LH is increased, the FSH containing gonadotropins are indicated, whereas if serum FSH more than 10 milli-international per ml, LH and FSH is used for ovarian stimulation. In the patients with hypogonadotropic hypogonadism, a combination of LH and FSH is used. Different regimens of gonadotropins. The conventional regimen, low dose step up regime and the step down regime. Usually, we use the step up only, the 75 to 150 international step up. We have to give 37.5, 75, 112.5, 150. While in the step down, it is reported in the literature, but we are not using 150, 112.5, and then 75 once the follicle reaches the more than 10 mm. So, in the conventional regimen, the CC resistant or CC failure cases started from day 2 or day 3, 75 to 150 international units per day, serial USG for monitoring, day 8 serum estradiol, widely accepted protocol. The pregnancy rates are reported up to 30%. So low dose setup regimen, it is useful in the cases of the PCOS. The aim is there to threshold the level of FSH which lead to the development of a single pre-ovulatory follicle. So usually we are using this step up only because in the cases of the IUI, we are not usually doing in every patient the hormones level of the estradiol and FSH because that will increase the cost. But whatsoever is reported in the literature, I have shown. So stepwise to increase in the subsequent doses, E2 and USG on day 7. Day 8, if E2 is more than 200 picogram per ml, ovarian follicle more than 10 mm, continue the same dose. If not achieved, then have to increase by 37.5. Then in a step down to start from 150 international units per day from day 2, continue till the dominant follicle become 10 mm on USG, decrease the dose 112.5 international units per day for next 3 days, 75 international units till the time of HCG. Just a second, friends, the light has gone. I have to change the internet. Sorry for that. Yeah. So, CC with gonadotropins, the sequential use of the CC followed by FSH or HMG, the CC 100 mg 1 daily from day to day 6, FSH or HMG 75 to 150 on day 6 and 8, TVS on day 8 onwards, additional FSH and HMG given. So advantages of CC and HMG, the higher pregnancy rate than with the CC alone, more cost effective as the dosage of gonadotropins is reduced, less multiple pregnancy rate than with the gonadotropins alone, lower incidence of OHSS as compared to the conventional regimen. Then letrozole with gonadotropins, a good alternative to CC in the patients with unexplained infertility undergoing gonadotropin stimulation and COH cycles combined with IUI therapy. The pregnancy rates was significantly lower in the cases of CC plus FSH group compared with the letrozole and FSH group, and then only FSH. As I told you, with the gonadotropins, the results are much better. So, but of course, the budget is the main issue. Sorry. Yeah. So then the GnRH analog with gonadotropins, the studies have shown that 15 to 20% the cycles of CC or HMG due to multifollicular development, estradiol increases, premature LSR, and then for the cycle cancellation. To avoid the endogenous LH interference, exogenous gonadotropins and GnRH analogs are used for ovulation induction, mainly in the IVF. Nothing like such data that it improves the pregnancy rates in IUI. Then in the antagonist, the competitive inhibition of GnRH receptors, which results in a rapid decline in FSH and LH levels and thus preventing the premature LH surge, can be given in a single dose or daily dose regimen. Among this antagonist protocol, the two protocols are very famous. One is the Lubeck protocol. The gonadotropins are started as usual, and antagonist is started when the follicle reaches a size of 14 mm or from the 6th day of stimulation onwards in a dose of 0.25 mg per day till the day of the HCG injection. So, useful in the cases where the procedure has to be avoided in the weekend or in the holiday. The French protocol, in which the gonadotropins are started as usual and a single dose of 3 mg of antagonist is given when the level, serum E2 level is about 150 to 200 picogram per ml and the follicular size is 14 mm. Advantages of the antagonist protocol, it allows the manipulation of the follicular development so that the IUI can be avoided at weekends without any detrimental effect on pregnancy rate. It is simple and inexpensive, no suppression of estrogen, and effects are easily reversible, while the antagonists are associated with lower rates of OHSS. So overall, the pregnancy rates are associated with the use of the aromatase inhibitor for ovarian stimulation. Here we can see, friends, CC, FSH, letrozole, and with the gonadotropins. Of course, we can see the studies have shown around the comparative study between the letrozole and the gonadotropins, but of course, the proper monitoring is must. Then, yes, of course, once I am taking for this IUI, a word about the tamoxifen due to the anti-estrogenic effect. 20 mg per day for 5 days starting on day 3. up to 40 mg per day, no response. The advantages are no anti-estrogenic effect on endometrium and cervical mucus, and it can be used in the patients with thin endometrium, family history of breast cancer. So the follicle monitoring, of course, we have to start the day 2 TVS is important to know any residual cyst and what is the basic antral follicle count. Then the start TVS from day 8. Normally the follicle growth 2 to 3 per day helps in determining exact time to trigger the ovulation. To prevent the OHS's endometrium, look for the thickness and appearance triple line. ET of more than 7 should be must. So less than 7 and more than 14, both are not good. Um, so serum estradiol levels, though, yes, in my practice, I am not doing in every patient because it increases the cost, but whatever is mentioned in the literature and has been done by some centers, so I'm showing if the value is more than 200 picogram per ml, the good response the studies have shown. So if more than 4 follicles of 16 or more than 8 follicles of or more, or more than 8 follicles of more than 12 in that case, and serum estradiol level is more than 1500 to 2000 picogram per ml, then we have to cancel the cycle. And if the estradiol level is more than 1500, we have to use the GnRH analog to trigger instead of giving the routine HCG. Then urinary LH assays has also been done. And still in these days, again, some patients are coming by seeing the different kind of ad that, madam, we are using this LH kit, we are not having the time or to come daily for the sonography monitoring. So yes, they can go for the LH search also, but somehow I am not in the favor. It is reported in the literature. That's why I have shown this PPT. So timing, as we all know, 36 to 38 hours after the HCG administration or after the confirmation of the ovulation. Yes, in my practice, I do after the confirmation of ovulation. Yes, now is the HCG is necessary? HCG is necessary as the LH secreted by the body may not be adequate enough to induce the necessarily maturational changes in all oocytes. If there are many follicles in the ovary, numerous urinary LH kits are available to detect the LH. Search. So, because my topic is main today is to how to maintain, get the good follicle. So, and basically lot of doctors having a query related to the use of this CC and letrozole. So, my slides are focused today on that. If there are any related questions, I will be happy to answer. Mm.
So, doctor, there are questions. I'll just tell you. I'll just repeat
Yeah,
it.
yeah,
How important is the role of nutrition and overall health and success of the fertility treatments? Like,
very,
what
very
is
nice.
the, yeah.
Yeah, very nice question. So, of course, the role of the nutrition and fertility is very, in the treatment of the infertility is very, very important. First and foremost, what we tell the patient, the body mass index should be correct. Weight ज़्यादा नहीं होना चाहिए. If the weight is more, definitely in the patients of the PCOS, of course, we are not getting the good follicles. Yes, we tell the patients to have a good nutritious diet. Avoiding of the junk food is very important. Try to include the fresh green leafy vegetables. We all know that is a good source of folic acid also. They can include the omega fatty acids in the form of the different seeds. These days we are seeing lot of reels, lot of advertisements are coming for the different seeds. So they can include the different seeds that all will be good. Flax seeds are good, pumpkin seeds are good. Almonds they can take walnut, but the moderation is the key. Not like that if the doctor is telling you to take the seeds, not like that a bunch of seeds you have to take. Only a fistful, or we as usually we recommend, yes, 5 to 6 almonds, 2 to 3 walnuts. We usually recommend. So of course the role of nutrition is very, very important. And one thing more, the change of the lifestyle. If before you ask me, the change of lifestyle before getting a good follicle, of course, we tell the patient that avoiding of the smoking and alcohol is also very, very important. Yes.
Doctor, the other question is what advice would you give patients to help them cope up with the emotional aspects of the fertility? Emotional
Most,
aspects, yeah.
you have to do a proper counseling. See, whenever we are having the patients of the this infertility, of course, patient पहले से ही इतना depressed होता है. And patient usually at my place also what I am getting the patient has मेरे पास कोई सिंपल पेशेंट नहीं आता. पेशेंट पहले इधर उधर जाकर आता है. बहुत 5 साल हो गए, 6 साल हो गए, 8 साल हो गए. Of course, the patient, if not getting the result, patient is already depressed. So I always explain the patient, if you think positive, then only you get the positive results. Yes, of course, the emotional counseling is very important. If you are a very busy practitioner, then you have to appoint some separate counselor along with you. But what I suggest, आप जो counseling करोगे, उसका जो effect आएगा, वो counselor के through नहीं आएगा. That is because patients are coming to us for the treatment on our name, that they want the doctor should tell us. So yes, the counseling is also very, very important.
Okay, ma'am, that's the questions for
Huh.
this session.
Okay,
Yes.
okay.
Ma'am, would you like to say anything for today's topic or any?
Mm. We will go now. We will go with the coming session with I will do with some other topic related to infertility or related to
Sure, sure.
PCOS. As lot of queries are come on this topic.
Okay.
You tell me, Sanika, what time is much better when the doctors are having a more comfortable time for attending the webinar?
Mostly, ma'am, it's the noon because most of ma'am, can we talk this after the session? Yeah, because
Yes,
now
yes, yes,
most
yes.
of the people. I'll just give you a
Yes,
big thank
yeah,
you to our
yeah,
esteemed speaker, Dr.
yeah.
Ritu, and for gracing us with her expertise and profound insights. And to attentive audience, we extend our gratitude for your engaging questions and enthusiastic participation. Thank you once again, ma'am, for being a part of this insightful webinar. We eagerly anticipate your presence at our future events where we will continue to explore and learn together, ma'am.
Bye. Thank you, dear. Thank
We'll
you,
talk
Sanika.
soon.
Yeah. Thank you, Medisage. Yeah. And thank you, dear friends, those who all have joined. Yeah. Bye bye.